Good morning, everybody. And just to make us really feel like we're in family medicine, we're going to have a presentation today specifically around patient-centered care. And I'm going to focus around the chronic disease visit. And we're actually going to use an example of a typical patient you might see in a family medicine outpatient setting and just give you a feeling of what we mean by patient-centered care. And what we're actually going to do today is we're going to have a little bit of a paradigm shift. Because although we use the words patient-centered care and Batupele and Ubuntu and these concepts quite frequently, it's not actually the way medicine has been working for the last, 100 years. And so we're going to experiment a little bit with some new approaches and some new ideas. And what's interesting around patient-centered care is there's always a feeling that, well, I'll do patient-centered care when I have more time. But actually, if you do patient-centered care, you will actually be able to have a more efficient, maybe not faster, but it's more efficient and a more effective consultation. Probably take about the same time, but your patient's going to leave happier and will probably do better. So there's actually lots of science around the patient-centered consultation to show that it's actually is important. And of course, obviously, there's lots of evidence around improved patient satisfaction, but there's also good evidence that it actually improves biomedical outcomes. It definitely reduces adverse event outcomes due to prescribing. It reduces our patients' anxiety, and it makes the consultation more efficient because you're actually going to deal with the issue of why the patient is there. And it's amazing how often we miss the reason why the patient is actually sitting in your room. So great. So what do we mean by patient-centered care? So let's just contrast these two. And when I'm talking about doctor versus patient-centered care, I'm talking about high quality, both of them are high quality care systems, but the doctor-centered care, I'm going to call the noble cause. And this is how we've all been trained. This is how our academic universities work. And the idea is that your purpose is to diagnose the disease or identify the risks of disease. And you're going to do it through all those history taking, examination, investigations, all those clever tools and things that you've learned. And then you're going to come up with a suitable plan or treatment of intervention to help your patient. And the goal is to restore your patient to health and to prevent any further complications and to prevent disease. And this certainly feels like a very sensible way to approach medicine. And if you think of all our guidelines, we very much have a public health approach. And we have this idea. So for a diabetic patient, what is the best things that we can do for a diabetic? For our hypertension patient, what is the best things we can do? And this is the doctor-centered cause, and we all are very much well-trained in this. So what do we mean by patient-centered care? With a patient-centered care, what's happening in the consultation is the patient's agenda becomes the most important part of the consultation, not the doctor's agenda. So the purpose of the consultation is therefore to identify and help the patient identify what their agenda is, and we're going to talk about that. And then you use all these amazing things that you've learned through inquiry, examination, investigations, etc., to assist the patient to come up with the best plan to help them meet their agenda. So in the patient-centered agenda, you are not the great one coming with the answers, you are the one coming with information, and you're going to serve the patient of where they are at. And therefore, the focus around this is not actually so much public health, but service delivery and patient satisfaction. Now, although it feels like an either or, we actually need to obviously have both when we are good doctors, and we need to keep both in mind. We need to be able to give our patients some of these great knowledges that we have. But I think I want us to really focus on this patient-centered for a little bit as a balance, because in general, when we get in a hurry, and most of the examples we've seen is going to be in doctor-centered consultations. So I want to encourage you to experiment with what a patient-centered consultation would like. So I worked in the UK for 10 years, and they got very doctor-centered agendas as well there in the practices, and so much so now that you get paid. If you're an NHS GP, I worked in an NHS practice, and you would get paid on how many patients' blood pressures you've done. If your HbA1c is on track, you would do everything on computers. They'll keep track of your quality markers, and then you would get bonuses or points and get paid accordingly. So my doctor, who was living in England at the time, was struggling with a little bit of anxiety, and he was really struggling to sleep at night. He was worrying about things, struggling to go to bed. My mom was getting worried. So she sent him off to the NHS GP. He, of course, refused for my mother to go with. And when we came back that evening, we were like, well, what did the doctor say? And the doctor gave him a couple of tips on sleeping and spent the rest of the consultation doing his waist circumference, his BMI, doing his blood pressure, taking his cholesterol levels. And you can see how that appointment had got hijacked by the doctor-centered agenda, and my dad's anxiety was never actually dealt with. So I'm going to bring up a few sort of theoretical frameworks for us to understand a little bit where our patients are from. And this is a very common framework that I'm actually working on. It's also part of what I'm doing in my master's at the moment, which is a little bit of understanding human behavior and a little bit understanding some of the dynamics that is coming into that consultation. And I like to call this my double and I, meaning that each of us has two parts, you can almost say, two parts of your brain that leads your behavior whenever you go through the day. So you have yourself, your name, and who you are, and then you have another, a double, who looks exactly like you. It's got your same name, looks just like you, dresses exactly the same, but it behaves very differently from who you are. What do I mean by that? So to understand that, I like to use the analogy of thinking of your brain, your neurophysiological system, as having two systems that has to deal with the world. The one system is your survival system, right? Remember the old limbic brain that's been with us for centuries? This is your fight-flight response. This is where you avoid any pain. This is where you've got certain drives. So certain things are important to your survival system. You need to have food. You need to be safe. Your troop, your family, your friends. You need to have some power, intimacy, and sex. And I want you to think of the survival brain as a beautiful, powerful, but rather stupid dragon. Then we have another part of ourselves, which is the prefrontal cortex. That's much later in our development. And this prefrontal cortex brings qualities that are specific to human beings. Makes it possible for us to be self-aware, makes it possible for us to be empathic, makes it possible for us to reflect on things that's happened, and it gives us the possibility to have control, meaning to be able to control this dragon. So you can imagine you have this master that has to manage this beautiful, powerful dragon, and this dragon master is where all our true values lie. When these two are beautifully integrated, so your whole brain is present, then I call that the authentic self. This is the person who then presents to the world, and this is where you are in your best self, and we'll look at a few examples of that. But what sometimes happens is when we are stressed or frustrated or tired, sometimes the survival brain kicks in. And when the survival brain kicks in, we literally cut off all the blood supply to our prefrontal cortex. And this is what I call the double. This other person steps forward that's responding out of survival needs and not taking into consideration our higher self. And you've all had your days where you think, why did I do that? Or, I can't believe I actually behaved like that. So what switches you between these two modes? So we have this limbic brain-led system, and we have this authentic self system. And of course, the thing that's going to trigger this limbic brain survival system is adrenaline. So anything that's going to make you feel threatened, any threat to your physical safety, emotional safety, or freedom of expression is going to trigger adrenaline in your system. And this is a physiological reality. So if you're feeling stressed, you are most likely going to be operating from your lower self. So I'm going to go through the next couple of slides quite quickly. I've got a whole presentation where I cover this in a lot of detail, but it's just to be able to start recognizing a little bit who you are when you are in your consulting room. So when you are in street view or in survival mode, I call it street view because you literally can only see what's just right in front of you. You're very much focused on the present moment. Your priority is survival, and we're quite paranoid and vigilant when we're in that mode, or sensitive. And remember, this is genetically programmed to try and keep us safe. We will be using certain networks in our brain to make fast, quick decisions. This is where we make assumptions, jump to conclusions. Whenever you've heard about bias, whether it's confirmation bias or narrative bias, that's this fast thinking, jumping into action. And this kind of thinking is quite unstable and very inconsistent. This is a powerful way that we use it all the time. So in social media, especially, when you're scrolling, you read that, you read the first sentence, you haven't even finished the paragraph and you already have a response to whatever is happening. It's a very powerful mechanism that keeps us safe. but it's not the smartest part of ourselves. So if we're in dragon mode and there's no survival brain, no higher self present, this survival system is there to keep us safe. So it's actually quite satisfying to be in a rage. Have you had that experience when you see that road rage? It feels like I'm doing something. And one can become very self-focused when people are being quite proud or insecure, they're in that mode. And we see this on social media, this extraordinary emotive judgment that comes when you're in that mode. And you've all been on the receiving end of posting something innocuous and then watching the comments come through. This is where people get aggressive, and this is where things get dangerous. And the results of everything you see in an A&E setting on a weekend is usually to do with dragons making trouble. So the mechanisms, again, in my other presentations, I cover in quite a lot of detail. I'll just show them quickly because these are mechanisms that we all use to help us manage our anxiety. It's little complex sets of behaviors that we've already started forming, habits we've formed since childhood to make us feel less anxious. And when you see these behaviors, it's a way to identify whether you yourself or whether somebody else might be in dragon mode. So when you're in dragon mode, you've got these little things you do that usually makes things worse. That's why we call them saboteurs. So for example, it's very satisfying when you're stressed to criticize, to overanalyze. You know, we all do that. We preach to our patients, to try and manipulate other people and try and you'll see the qualities there in brackets are the strengths that we have that we then use when we are in these modes. Under freeze, we might be, if we're quite kind people, we might be pleased. We hope if we're nice to somebody else, they might be nice to us back. We fixate on details. So some people can become quite obsessive. So they struggle to hand something in because it has to be perfect, or be obsessively cleaning or obsessively tidying up without getting to your studies. We've all had 3 o'clock in the morning worrying about stuff, your head going round and round and round, trying to sort things out, which you can't sort out at 3 o'clock in the morning. And then we have avoidance. So you have to deal with a difficult situation and you decide, well, I'm just going to stay in bed today, not going to work. Feeling sorry for yourself. We've all had that when you're on call, 3 o'clock in the morning again. And then distracting, that is, of course, the basis of all our addictive disorders is when you're using Netflix binging or alcohol or drugs or whatever it is to help you deal with your anxiety. So these are just the kinds of behaviors that tells us somebody is actually feeling very stressed. When our patients are coming through our doors, a lot of them are worried and stressed about something, and you might meet some of these behaviors in the consulting room. What we want to try and get to as a patient-centered doctor is how do we manage to meet our patients from our authentic self? And part of that means managing your own anxiety and stress. And if you are able to really bring your whole self to that appointment, then you are able to really function from this higher level. Now you're able to see things in context and with perspective. Now you're actually able to make choices in terms of what you want your life to be like. This is where we're able to bring focus and attention to effort to something. Now you can interpret information. You can be logical and rational about what's happening. And this kind of thinking is much slower, takes more work. You literally have to burn more energy, but this is much more intelligent. This is where you're going to come up with a really clever diagnosis or exactly the right way to manage that patient. So again, if you're in an A&E setting and you're stressed, you're going to really struggle to manage that situation well. If you're on a calm state and you're able to access your whole brain, now you're going to be able to really manage a complex situation well. But also when we are our authentic selves, this is where we're able to be compassionate and tolerant. This is where we're able to be humble and generous to others, where we're able to be creative and innovative and flexible. And very important, where we can be generous in our assumptions. And this is probably going to be one of the most important things I want you to take into your consulting room. We need to be generous to our patients. We can't judge about how or what or why they do the things they do. We do not know their life stories. And we all need people to be a little bit gracious to us sometimes in terms of where we're at. So creating that graciousness in the consulting room, very important. So there's lots of aspects of this dragon, and I want to speak specifically around power. So remember, I talked about those things that the dragon world needs. So around power, troop, food, security, and all of that. The reason why I want to focus on power is because in the consulting room, there is a very much a discrepant power between you as the doctor and the patient. And being aware of what that power dynamic is and working with that power dynamic is a very important part of how to create safety in a patient-centered care kind of consultation. Who of you have seen the Wheel of Power before? Really not aware. Okay, so this has actually been devised very much by Sylvia Duckworth in the world of refugees. So it's one of the big things that NGOs working in refugee areas work with to help and make their workers aware about what we mean by this wheel of power. And this is actually where the word marginalized comes from. So in the center here are certain unearned advantages that puts you closer to power within a society. And the more you are towards the margin, the more you have unearned disadvantages that puts you more on the margins in terms of power within a society. So generally, I mean, this is a global wheel, but if you are white, if you've got post-secondary education, if you're able-bodied, if you're heterosexual, if you're neurotypical, if you've got a robust mental health, if you're slim, if you own property, if you're rich, if you're English-speaking, or if you're a cisgendered man, if you're a citizen in the country, all of this puts you closer to this center of power, which means you have the ability to decide what happens in the society around you, and you have power to decide what happens in your own life. You might not even be aware of that amount of power that you have, but people who are very aware of that difference are people who are sitting around the margins. So the darker your skin is, the less education you might have, the more disability you might have, the more your sexuality falls on the marginalized levels, the more neurodiverse you are, etc. All of this means you have much less ability to influence what's happening in society around you. So historically, those with power has always had the power to decide what happens to people that is sitting in the margins. So all systems of classification, marginalization, discrimination, oppression, South Africa, our history was a very good example of how white men specifically made decisions about what should happen about people who are not like that. So the apartheid system was showing how the opinion of those in power suppressed those that were around the margins. And I just come back from the SAHI conference where we had a lot of discussion actually also within universities and within educational grounds of how we have to become more and more aware also within our classrooms of making sure we create inclusive safe spaces for those of also that sitting on the margins and helping them to have power within our classrooms. A lot of our patients, especially in our areas here, who are sitting in your room, are sitting within those marginalized societies. They do not have much power always to influence what's happening in their lives. And when they are sitting in the room, there are some underlying safety questions that are there that's already influencing the dynamics. And these are not necessarily conscious things, but every patient already is wondering, are you with me or are you against me? And the more marginalized you are, the more that concern is. So we've had a challenge, for example, with people with LGBTQIA+ communities not accessing healthcare because they don't know if the healthcare professional sitting in front of them is for them or against them. Wondering what's going to happen to me, nervous about the outcomes of the consultations, having this feeling I'm more important or less important than this doctor sitting in front of me, and will I get a say or will I not get a say in what's going to happen? So let's take an example of a typical case you will see down in Ward 5. Got a 58-year-old lady. She's a widow. She lives with her daughter and her grandchildren. And she comes in with a whole bang shoot. She's got diabetes, hypertension, dyslipidemia, and some CKD. All her bloods and blood pressure and things have been on target when she was last seen 3 months ago. And she's typically on a high carb-based diet because that's what she can afford in a fairly sedentary lifestyle. She was diagnosed in 2019, and then 2022, she came to us because her HbA1c was not yet on target. And now she's on a whole range of different drugs. So she's on metformin, she's already on actrafane, she's on furosemide because of a CKD for her hypertension, and she's on enalapril and some simvastatin. So I want us to start just wondering, imagining a little bit what Mrs. Nabo's life is like. So, you know, our patients arrive here very early in the morning. So she's actually from Berlin. She had to catch 2 taxis just to get to CMH. She got up very early that morning, and by 7:30 she was here. She went to collect her folder. She's got number 16 on her queue, which means she'll probably only be seen by 11 o'clock already. And she's one of the earlier ones. And it's a normal review date, but she's had a very sore lower back over the last week. And now she's sitting in the waiting room, and she's not sitting there with a blank mind. Her mind is busy. She's got all kinds of things she's wondering about. She's wondering what's wrong with her back. She hasn't told her daughter about all of this, and she's wondering if she should or shouldn't have. She's got all these lists of things that she thinks she mustn't forget to tell the doctor, scared she's going to forget. She's got other things that also has to happen today. So now that she's in town, she needs to get to Mdantsane Mall, and there's some stuff she has to pick up for her granddaughter for school. And then there's all kinds of other worries that's also happening in the life around her. All our patients have this rich inner life that is happening before they finally get called and walk into your room. So let's look a little bit and take us through the consultation and change it all a little bit into a patient-centered point of view. And we all know the classic SOAP. So you've got your subjective, your objective, your assessment, and your plan. And now what we're going to do is, for our subjective, we're going to look at how we connect with our patient. We're going to look at how we do something called an hypothesis-driven examination. We're going to look in our assessment how we prioritize according to our patient's agenda. And we're going to look in terms of our planning, in terms of how we engage cooperation for that plan. So let's start with our subjective when you're taking a history. And a very important part is we always talk about rapport. And rapport has to do about that creating safety. And that happens already in the first few minutes that that patient walks into the room. So this power that I talked about earlier, the fact that you've got doctor in front of your title already means that that power balance is already there. And so we have to try and find ways to moderate or make it a little bit less, try and balance that power that we are experiencing. And one of the first ways we do that is by the way that we organize our consulting room. So when we do, have any of you heard about closed and open consultations? Universities, we need to go back to basics. So the way you arrange your room and the way you create the furniture in the room creates a power dynamic. Financial advisors know this. They have huge tables with massive big chairs, and then you sit on a little chair at the end, right? Mm-hmm. So closed consultation is when you have a barrier between you and the patient. So quite often there's a table, I'm on this side, the patient's on that side, and then these days sometimes you have a big computer screen with you here as well, and that creates a barrier between you and the patient. An open consultation style, which I think most of our offices should have because I keep on moving them around, is that you're using the desk as a place to write on, but you create an open space between yourself and the patient, and ideally both your chairs should be the same height, so that you create that we are working as a team together on something. And ideally, you want to also think about infection control, so make sure that the window's here, the patient's sitting here, I'm sitting here, and then therefore the air can move from the door, past me, past the patient, out the window. And we have both an open consulting style, and we've thought about infection control. So firstly, you want to ask your first question, and it doesn't matter too much, unless you want to start not with what's your illness, but obviously we're quite good with what's on your mind. What can I assist you with today? And Kosa asking, do you have a problem today? But what's very important is what happens after you've asked the question. And there's something called the golden minute. This has actually been quite well researched. It was first introduced by Roger Neighbor, who wrote an extraordinary book called The Inner Consultation when I specialized 20 years ago now. This was the hot book in terms of consultation style. And they started actually doing research on how long it takes before we as doctors actually interrupt our patient. So the first 60 sections, the first challenge, your only challenge really, if anything you learn from today, is just to shut up for at least the first 60 seconds. Sounds easy, but actually in studies they have shown that doctors on average interrupt within the first 11 seconds. Even though most patients can actually, doesn't take even that long, it takes less than a minute for most patients to tell you their whole story. What typically happens is the patient will come in and says, well, doctor, I've had a cough, and you will go, when did it stop? And suddenly you're down the TB questions already. So being able to create that possibility, because remember, the poor patient has been rehearsing now what they've got to say. They've got a whole plan of how they're going to explain it. And you need to give them the opportunity to actually say what's on their mind. And that also gives them the experience that you're there to listen and you're actually interested in why they've come to you. So they've actually done some studies on this. This was done in internal medicine, and they've discovered that respecting the golden minute has got what they call the doorknob phenomenon. So that is what you've done your consultation, you've written your script, everything's done, the patient's about to go, and they go, oh, doctor, just one more thing, and then it comes, right? So definitely have higher patient satisfaction. And very importantly, they've actually shown that just that is correlated with less litigation, because the patient actually feels, because you might actually pick up what the patient was looking for. So the next question we want to look at is the or question. And this is now after your patient has spoken, and that's the what else question. So your patient has told you a thing, and then you go, and what else? And the patient speaks, and what else? The what else questions make sure the patient has the opportunity to bring up everything that's in their mind. And then the first thing we want to do before we go into a vast amount of questioning is start getting an idea where our patient is from. So we teach our students RICEF. I'm not sure who of you had learned RICEF at medical schools, depending on where you've come from. RICEF is just a mnemonic to help us try and identify what the patient's agenda is, what's going on in their mind. The R stands for trying to find out the reason, and this is not the medical reason, it's the emotional reason behind why they're coming. So what is it that's, I'm worried about something, or I can't bear this anymore, or somebody told me something. And then very important to try and start figuring out what are the ideas and concerns from the patient's point of view about what they think is happening. What are they expecting today? And then there's also something called the ice cubed, where they've got various E's at the end there. But you want to start thinking on how is this all affecting my patient? How is it affecting my patient's emotions? How is this affecting my patient's functioning? So all of this is just a very, and it doesn't take very long to do this history, but it starts giving you an idea of what is my patient brought into the consulting room today. So just a couple of words about health beliefs. When I specialized, they did a big emphasis on this. You have to what they call elicit the health beliefs of the patient, because there's different ways in how people think about health. This is a book from Ken Wilber. This was already written 30 years ago. They actually used this during the 94 transition to try and understand that different people come from different frameworks and that one framework is not more important than another. So for example, if you come from a very small rural village, you might have strong relationships to your ancestors, and therefore you might think something was bewitched. And we have to be careful to not assume that our framework of the world is more correct than the patient's framework of the world. Quite often in our young men, there's a very strong connection to my physical health is to do with my own power. So there was a book written with HIV, when we first started putting up HIV services in Lusikisiki, called The Three-Letter Plague, looking at why young men do not test for HIV. We was finally bringing HIV testing into the areas. And they found that this idea of having HIV in your blood was felt as a weakness, that somehow you are not, and we see this as a challenge as well with health-seeking behavior, for example, when people are going through initiation ceremonies, where by not managing, it means that you are physically weak. If you have strong religious beliefs, your patients might have a specific religion where prayer is very important as part of their healing journey. Of course, in the medical circle, we all believe that it's all about evidence-based medicine, and that's the only quite often perspective we have. And it's quite interesting. Sometimes you might even have different perspectives depending on which circles you're moving in. And then there's also very strong sort of almost a movement beyond evidence-based medicine that's looking at the natural healing power of the body and all of your complementary medical sciences. The challenge is that quite often what happens is your patient comes in with their health perspective, and the language we use to explain to them what's going on with them is all in orange language, all evidence-based. So if you don't understand how your patient thinks about the world, and now you dump a whole lot of medical framed medicine, even if you use all the nice language, but you're using a medical framework, your patient is probably not going to understand or being able to relate to what you're saying. So let's start a little bit with Mrs. Nabo. So I like to meet my patients at the door when I call them through. It's good for me to stand up every now and then. We also go through and call our patients through. When your patient comes to the door, greeting up at the door and making eye contact. It doesn't have to be aggressive Western eye contact, but making the patient feel that I see you and I welcome you in my room already creates a different power dynamic. So once you sit down, you ask her what the problem is, and she goes, no, I'm fine. Doctor, I'm just got a bit of back pain. You're not encouragingly because it's in the first minute, so you're not saying anything. And now she goes, well, I've been a bit worried about it, doc. Sometimes I have to stop what I'm doing because the pain is so bad. And I'm hoping it's nothing serious. That's what we call a cue. So already we can see there's something that's been going on in her mind when she was sitting in that waiting room. Anyway, she goes quiet. And so we do our all question. And what else, Mama? Anything else you need help with today? Yes, doctor, and I'm struggling at night. I have to go to the loo all the time, and with my back, it's been hard. And what else? So keep asking the question until the patient say to you, no, nothing else, doc, thank you. So now we want to try and find out a little bit about what, we want to follow up on that cue. So, Mom, I hear you're very worried about this back pain. What do you think it is, Mama? What is making you so worried? Hi, doc. My sister, she died of cancer and she had terrible back pain in the end. I'm the one looking after the grandchildren. I can't die now. So you can see there's this whole thing connected to what's happened to her in the past. And then very important always, if you're using your reflective active listening, we now want to try and find out what her expectations are. So I can see you're very worried about this. What were you hoping I would do for you today for the back pain? What are you expecting today? Maybe an X-ray, doctor, just to make sure there's nothing wrong. So when you've got that initial history that you've taken, we're obviously not going to work through the whole history taking. You want to get to the point when you've done your subjective that you now actually summarizes back to make sure that you and your patient's on the same page before you start going into your examination. So it gives you an opportunity to clarify and take all the relevant history, and then we can move on to the chronic review visit, which is actually your agenda. So first you make sure I've got my patient's agenda, and now I'm going to focus on what my agenda is. So now we're moving on to my agenda. Okay, Mama, so I can see you collecting treatment for your diabetes and your pressure today. You're worried about this back pain and you want us to check that something is not terrible like the cancer, and you're worried about going to the loo too much at night. Yes, doctor, it's just like that. Okay, there are a few more things I need to know, and then I will have a look at that back of yours. So very important, so you might take more history, but you need to know that the back is important to you. So now you're going to take your key history. You're going to start with your main complaint. Just remember, in terms of the chronic review visit for your diabetes and your hypertension, etc., there's the 5 C's, we call it. That's why we use the word compliance, not really such a cool word, but it remembers the 5 C's. So for any chronic condition, we want to check, how are they taking their treatment well? Remember, you can't ask people, are they taking their treatment well? Because the answer has to be yes. So one way of asking people is always just to say, it's difficult to take so many tablets. How many do you miss in a week? And again, that takes away this assumption that we're all taking our tablets beautifully all the time. Check if there's any side effects, if there's any complications of the illness. Check what the control is with the last HbA1c, and if there's any other comorbid disease you want to consider. Now you're going to move on to your focused examination. And targeted examination is essential for each consultation. And so you want to be clever. You cannot do a full examination on each patient. And we call that hypothesis-driven examination. So you want to look at specifically what's important. It's obviously good clinical practice, but also the better you examine your patient. It actually increases your, so for example, by examining the patient's back properly, you're going to make her feel much more reassured that actually you looked at the back. She's obviously an elderly patient, so an X-ray will be indicated. But if you've got somebody who's in 30s or 40s, and you've already seen, no, this patient's not going to need an X-ray, by doing a good examination of the back, it's going to be much easier to explain to the patient why you're not going to do that X-ray. If the patient has not got any complaints, so say she was just here for her medicine, please be aware that all our stable patients obviously need an in-depth review annually, but that means not at every visit. So I think one of the challenges for you as interns is when you see the patient, you're already just seeing this consultation, you're trying to do it all in one consultation. You're part of a family medicine team that's going to see that patient over years. So we want to find a balance between not doing a full examination every time and also not ignoring any examination and think, well, somebody else will do it. So one of the ways to do that is all our chronic patients need to have clearly identified when is their big annual review date. So we used to do that with HIV. So every year in February is your big annual review date. That's where we're going to do all the viral loads and all of those bloods. If you're diabetic, that's when we're going to do your eyes and your feet and your cardiovascular examination or your ECGs. And then the in-between visits, we can focus on the things that's important and where the patient's agenda is at. So we've examined Mrs. Onwaba's back nice and thoroughly. We noticed that her last review was 3 months ago, and she had all her full screening done at that time, and all her bloods was pretty good, and her EGFR actually improved from 43 to 55, and that's been staying quite stable, and a little bit of proteinuria. So when we now do a 3-stage assessment and we're creating a functional problem list, the way you want to do is you actually want to start with the patient's issue. They're important for the students in the back as well. When you're doing your IPAs, you don't want to start off with, oh, the patient's HIV and they missed their treatment as the most, because that's your agenda. Oh my goodness, they've missed their treatment. You want to start with what the patient's presenting complaint is, and that's the first thing you want to look at. Then you want to identify what is the relevant issues I'm going to deal with today. And sometimes you might find that there are too many issues to actually manage in one consultation. And then you have to prioritize, what am I going to look at today? So with Mrs. Somaba, we examined her. It looked like it was mechanical back pain. We did do an x-ray because of her age, which was NAD. We also figure out that she's still on furosemide, even though her GFR has recovered, and that she's actually taking a furosemide at night. And they've got an outdoor loo, and you can see why this is all getting very complicated. And we've checked all her chronic diseases. In her case, all of that is pretty much on track, but we're a little bit worried about that diet and lifestyle. So now we're going to make a plan for our patient. And in family medicine, we often talk about this elicit, provide, elicit. We're very bad at that. I think it's also because we feel rushed. But again, this can save you time. Always first find out what your patient knows or where your patient is at before you give information. Because quite often you're giving information of either stuff they already know, or it's stuff that's so disconnected to what they think they know that they can't follow you. So by knowing where your patient's at, you can give much more focused advice in terms of where we're going to go next. So after you've elicited your patients or where they're at, you want to ask them as well, after you've provided information, what they would like to see that happen, what they think about this information, and how you can help them with that. So first on your plan is always to address your patient's concerns. And second on your plan is to just deal with those specific issues you want to manage today. And this is very important. It's very appropriate to decide there's some things I'm not going to look at today, but then make a note to make sure it'll be picked up in a future consultation. So we need to start working together as like a one clinician that's seeing the patient over time. And then at the end, the treatment plan has to be handed over to the patient. The patient must feel that this is their treatment plan. So Mama, this and this and this is what we're going to do. And are you happy with that? So with Mrs. Onabo, we're going to give her some, obviously manage her back. We're going to sort her out that furosemide. If she needs to have furosemide, you could move it to lunchtime. But we could actually switch it to hydrochlorothiazide, and we're going to continue the chronic treatment and identify her annual review date, which is in October. So if somebody's chronically ill and everything is stable, then we could usually get away with 6 monthly. Otherwise, if there's still things that you are trying to adjust and get onto target, then you might be seeing them more frequently. And then we might now choose a particular thing. So the patient-centered thing was dealing with the back. And we might now decide, is there something I want to deal with from a doctor point of view? And I'm a little bit concerned about the diet. So we chat a little bit using brief behavioral session. I'll send you a little presentation on that as well. And we just identify things we need to change. So one of the challenges quite often as doctors, we feel like we should give our patient the complete meal plan. If you want to do a meal plan, rather send them to the dietitians. They can do that over time. But if you give a patient a whole meal plan, they're not going to do a single thing that's on that meal plan. You need a lot of time to be able to actually identify what they're eating and to help change that. And think of all of you, how many of you have actually managed to dramatically change the way you eat overnight? So one of the ways to think about dietary advice and exercise advice is finding one small thing they can change and identifying together, maybe so in her case, she quite likes her Twizzler, being able to say, okay, well, let's just go on to sugar-free drinks, or at least cut out the sugar-free drinks and make one small shift at a time. And you can make a little note. Next time we can talk a little bit about exercise, for example. So of course, part of a family medicine visit is to look a little bit at the long-term view as well of our patients. It's a bit of the public health side, and it depends a little bit on the patient. So again, opportunistic health screening does not mean you now try and find the whole list. Look at what's appropriate for your patient, look with how much you've already covered in that consultation, and is there perhaps one other thing we need to look at? So you want to think in terms of what are we doing now that might have a huge impact on the future. So this also includes your safety netting, so being able for the patient to know also when to come back. And one of the important things with safety netting is to start off with telling the patient what will happen when things go well. So it's a bit terrifying when you give the patient the script, no, you must come back when this and this and this happens. Start with the expectation. So for example, with our ARVs, I'm expecting you to have very little side effects on this treatment. This treatment is very well tolerated. I'm not expecting you to have any troubles, but occasionally people might have this and this and this. And if you develop yellow eyes or whatever, then please come back. So start off with giving a patient an idea. This is what I'm expecting. I'm expecting you to be a lot better, this cough to be a lot better within 2 to 3 days, for example. And then what to happen if things go not to plan. So with Mrs. Sonwaba, we might choose to discuss either pap smear or COVID, depending on what's relevant for her. Actually, vaccinations like influenza vaccination might be quite relevant at this time of the year for somebody with so many comorbid diseases. We want to empower her in terms of now managing what to do when this back pain recurs. And we wanted to create safety netting on what we want to look out for what she must come back earlier if need be. And very important, before you finish off, like we've had the golden minute in the beginning, at the end, have your unombuzo na, any questions, and actually give your patient time to see if there's anything else. Give them a second to actually think about it and be able to make sure that you've dealt with everything that's needed to be dealt with. So lastly, just to, after each, OPD can get very, very busy. And we want to be able to meet every patient from that authentic self. So what sometimes happens in the morning, you're all enthusiastic and you sit down and now the day gets busier and busier. And now you've had a patient which was quite complicated or quite difficult, or is a patient complaining in the queue and you're starting to feel off balance. And you need to be able to be aware of, how do I get back to my own self before I see every patient? And that can literally take 5, 10, 20 seconds. It doesn't have to take a long time to take a breath, have the door closed, and just find yourself, get your adrenaline levels down and get yourself back to that super duper doctor that you are. And if we can meet every patient at that place, the consultations themselves become exciting, innovative, creative consultations, and that will also help energize you throughout your day. So in conclusion, you cannot address your patient's agenda if you don't know what it is. So the only thing I want you to practice today is a little bit the golden minute and trying to understand what my patient is actually bringing. Listen for those cues and respond to them. By responding to a cue about the cancer, we were actually able to have a very efficient, quick consultation, and mom felt great. Mama can leave feeling very happy. Your ability to be curious and your ability to be interested are your greatest attributes at a doctor. So this is not an interrogation. It's like, I really want to find out about you and I really want to help. And if you can create that atmosphere in your consultation, you will already be creating a patient-centered consultation. Thank you very much, everybody.
Thanks, Madeleine. I'm sure